Thank you so much, Dr. Zahid, for conducting this session. I have a little announcement to make from Dr. Safia. Uh, the, they have a book on ICU management. The PSA Karachi chapter, along with Dow University of Health Scientists, has made a book on ICU, and it's available at the stall nearby in the foyer. So all of you who are interested, you may get it from there. To begin the next session, which is a panel discussion, I would like to call upon stage Dr. Sidra Javed to conduct the session. Thank you.
Assalamu alaikum and good afternoon, everyone. Today, I'm going to moderate a panel discussion on a very important topic, safe practice in blood transfusion and conservation, for which I would like to call our respected chairpersons, Professor Syed Tipu Sultan. I think he needs no introduction. He is teacher of many teachers, professors, and consultants all over Sindh. His list of accomplishments is substantial. He has served as head of Department of Anesthesia at Civil Hospital Karachi, where he is a pioneer of ICU unit. Sir, please. Our second chairperson is Professor Khalid Bashir. He is one of the top certified anesthesiologists in Lahore, having the degree of FCPS and MCPS. Currently, he is practicing at Hamid Latif Hospital. Respected chair, please call the panelists so I can start my presentation.
Okay, thank you very much. We have got 1 to 4 panelists. I would like to invite them. Number 1, Dr. Akhtar Aziz Khan. Number 2, Professor Nasreen Laik. Third, Khalid Samad.
Excuse me.
Khalid Samad.
Yeah, लगी नहीं. ये स्टार क्यों मेरे सामने?
Khalid Samad.
हाँ ये लगानी है. सामने क्यों नहीं?
तुम कहाँ छुपे हो भाई? And the last one, Professor Sirajuddin, Liaquat National. Thank you very much. Now we have got a panel of experts. So I will request moderator to go ahead, please.
Okay. The theme of our today's panel discussion is decision of red blood cell transfusion and blood conservative strategies in major surgeries. It is a very important topic for all the doctors, but it is part and parcel of our specialty. So let us begin. Okay, a 35-year-old man crashed his motorcycle on the highway and was brought to the emergency department in hemodynamically unstable condition. With blood pressure of 85 by 55 mm of mercury, heart rate was 128 per minute, respiratory rate was 30 per minute, and GCS was 8 by 15. His hemoglobin was 5.6 gram per deciliter, and X-ray showed massive pneumothorax, pulmonary contusion, an unstable pelvic fracture, and gas in the right diaphragm. In the emergency department, the patient had a primary survey and initial resuscitation was given. After intubation and placement of chest tube in the emergency department, the patient was transferred to the operation theatre. I would like Professor Nasreen Laik to please comment on this. What is the massive blood transfusion protocol and damage control resuscitation in this type of patients? I need your expert opinion, madam, please.
Okay, in this kind of scenario in which there is massive blood loss, in this case, we have some protocols known as massive blood transfusion protocols. It's a set of guidelines mainly applied in those patients where there is severe bleeding and coagulopathy, and we have to transfuse blood products in order to save the life of the patient. So in these guidelines, we have certain protocols to follow in order to save the life of the patient and in order to minimize the complications which are related to the transfusion associated, we can call it transfusion related complications. So, first of all, we have to recognize such patients as already Dr. Sidra has mentioned in the scenario that the patient has a pulse of I think 80 or 60, it's
Pulse 120 per
Yeah.
minute, blood pressure 80 by 55.
so the patient must be losing more than 2 liters or more than 40% of blood loss. First of all, we have to recognize and the patient that it's a patient of MBTB protocol must be given to this patient. So recognition is first. In recognition, we have to find about the vitals and the parameters, hemodynamic parameters like the patient will be unconscious, he or she will be pulseless or there will be thready pulse, and the patient will show signs of shock, and there will be pallor, and the mental status will be, he or she will be irritable. So these are the few signs of shock. So after recognition of the patient that he is a candidate for MBTP, we have to pass large bore cannulas secondly, and thereafter we first of all we have to maintain, as already Dr. Sidra has mentioned, that ABC must be maintained, airway must be maintained.
Madam, I want to know what should be the ratio of blood products in
Yeah,
these type of
I'm
patients?
coming to that.
Ji.
After maintaining ABCs, we should start crystallide and colloids as soon as possible, and meantime we have to call for the blood bank to arrange the blood products, and the blood products which should be given in such a scenario will be the packed red blood cells and the FFPs and the platelets. These products will be given in a ratio of 1:1 to 1. So all these each product should be given in a ratio of as I have mentioned. And at the same time, we have to check for the coagulopathies by ordering his or her investigation to the lab to look for the hemoglobin and
Okay,
PT,
madam.
FTT,
Thank you.
INR.
I am going
Yeah.
towards next question.
Okay, thank you.
A 7-year-old boy with no relevant medical history was admitted to the emergency department due to abdominal pain of acute onset after blunt abdominal trauma. He was alert and responsive. The blood pressure was 80 by 50 millimeter of mercury and pulse was 110 per minute. The laboratory test results revealed hemoglobin of 9.3 milligram per deciliter. Fast test was positive for free fluid in abdomen. After initial resuscitation, CT was performed which demonstrated intra-abdominal fluid with a grade 3 splenic and renal injury. He was shifted for urgent surgery to operation theatre. What should be transfusion trigger for a pediatric patient with blunt abdominal trauma and dropping hemoglobin level, and how to manage these type of patients intraoperatively? I would like Dr. Akhtar Aziz, can you please comment on pediatric trigger?
When you're talking about a transfusion trigger, normally the trigger that's internationally accepted is that the hemoglobin of 7 grams per deciliter, less than 7, or a hematocrit of less than 28. So right now this patient, as the case is, the hemoglobin is 9.3. Maybe by the time they shift him to the OR and by the time the patient is anesthetized, the hemoglobin might drop because a 7-year-old child who does not have a very large blood volume. the ideal thing would be to decide about giving the red blood cells or blood. It will depend on what the hemoglobin is at that particular moment. And I think the literature is very clear about it, about using point of care hemoglobin testers, which are very much accurate. They say there's less than a 0.5% error in it. So, if you do a hemoglobin, if it's a 0.3 gram per deciliter, either way.
Should we transfuse with hemoglobin of 9.6
No.
to the patient or not?
No, the trigger is
No.
trigger is 7 because there are two
But
different.
there is ongoing blood loss and concealed blood. But there is ongoing blood loss as there is third degree ischemic injury.
Yeah, that's what I said. They should do another one before starting transfusion. A point of care. If you send it to the lab for a CBC, the results will be too late. So point of care testing is the goal, is the standard.
So the key point is if point of care is present, you should do the point of care strategy. Okay. What are the blood conservation strategies to reduce the need of red blood cell transfusion in major surgeries? I would like anyone from the audience, anyone from the panelists wants to comment on this? And what different blood conservation strategies you employ at your institute?
Blood conservation strategies to reduce the need for red blood cells transfusion, and preoperatively you scan for anemia and what are the causes of anemia, treat the anemia before surgery, and second is that if any patient and on the anticoagulant, the anticoagulant should be stopped and restart according to guidelines. And if the patient have any hematological disorder, they should be treated before. And blood should be estimation of blood loss should be expected before the surgery. If the blood loss is more than 5, 6, 7, more than 700, you can think about cell saver, and these are the preoperative strategies. Now we have intraoperative strategies. The intraoperative strategies can you avoid hypothermia during surgery, and acidosis you avoid. You can have a cell saver, and you can have a fibrillar sealant and normovolumic hemodilation and anesthesia. If you have anesthesia, general anesthesia, as compared to general spinal anesthesia, there is a less chances of blood
Sir,
loss.
can we use cell salvage strategy in every patient?
Not
If-
every patient.
If a patient infected,
It is
or-
one of the option.
Okay.
It is one of the option. And then
Anyone from audience use this strategy? Cell salvage technique? Anyone? Okay. Okay, I
So
propose-
basically, the recent guidelines, this is by American Association for Advancement in Blood and Biotherapies. It was released in 2023. So they talked about this restrictive versus liberal therapy, especially for the kids. So they said that if the patient is having a biventricular problem, congenital heart disease, you can go for like 7 HP. And for univentricle, you can go for 7. And in between, patient is cyanotic congenital heart disease, you can go for 7 to 9. Regarding the conservation strategies for intraoperative management, there are different techniques available. That's a pre-autologous technique, and then there's a acute normovolumic hemodilation technique, and there is cell salvage technique. Apart from pharmacological therapies which are used, and the technique the surgeon is using, and other things that you can do that Dr. Siraj mentioned, that prevent hypothermia and positioning of the patient, and go for hypertensive anesthesia, just things like that. So you can, and pharmacological therapies. So mainly it depends, it's basically a multidisciplinary approach. You have to take the primary team in loop, you have to discuss with the blood bank, there the physician and the technician should be in the loop. With that, you made a policy regarding how to manage the patient coming with acute condition and how to manage the patient coming for the elective procedure requiring blood transfusion. Thank you very much.
I have a question from my junior colleagues from audience. For hospitalized hemodynamically stable adult patients, should we transfuse with a restrictive strategy or liberal strategy, and why? According to latest guidelines. Anyone from our junior colleagues? Anyone from my panelist? Any side effect of using liberal strategy? For hospitalized hemodynamically stable adult patients, should we transfuse with a restrictive strategy or liberal strategy?
Oh. The consensus now is that people should use, everybody is moving towards a restrictive strategy where not for the neonates, but for the adults and the pediatric population, nearly is the same, that don't give blood if the hemoglobin is above 7. They just don't want to expose patients to the hazards of a transfusion and developing some kind of allergic reaction or delayed immunity against it, so that they don't get, if they have a problem with the future transfusion, so they try not to give the blood. But there are other extremes where there are a lot of proponents who still use the liberal regime, and they transfuse patients as soon as the hemoglobin drops below 9. So there are two extremes. It was accepted in the past that patients with renal failure, 5 is acceptable.
Okay.
But that was an extreme.
Means for hemodynamic stable, 7 is acceptable. We should not make it 10 or 9.
Yeah.
Okay. Our last topic for discussion is a 79-year-old man presented to the emergency department reporting acute onset of abdominal and low back pain. His medical history was remarkable for known cardiovascular disease, including coronary artery disease with previous myocardial infarction and coronary artery bypass graft. He is also known case of hypertension, and he is using 31 pack year history of tobacco. He was vitally stable. The result of CT angiography showed 10 centimeter abdominal aortic aneurysm, a very serious case and very challenging for all the anesthetists. So, what is the utility of thromboelastography to guide blood transfusion in major vascular surgeries like this case? I want to know this from Professor Dr. Khalid Samad. Sir, please, will you guide me regarding TAC or other procedures?
Okay, so obviously I don't have the hemodynamics there. Did you show the blood pressure? Yeah. Can you show the blood pressures?
Patient's hemodynamic is stable.
Stable. Yes. So basically, when we are talking about a stable patient, then we have time to make arrangement and make preparations. So first of all, we would like to have arrange blood for this patient. Second, what we can do intraoperatively in this kind of patient is to go for some kind of technique to prevent spillage of the blood. We can use cell salvage technique in this patient, which is recommended in this kind of patient. The question regarding the use of point of care testing, now it is recommended to use monitoring of hemoglobin and monitoring of some kind of testing to see the coagulation profile of the blood, and thromboelastography and some other tests are coming in, and now they are recommended. But the thing is that for practical purposes, we need to have a system available in the operating room where from taking the sample and then putting it on the machine and then interpreting the result to get an idea what actually we want to give, because these tests give you an idea what patient is requiring if there is coagulopathy. Thromboscintigraphy will give you an idea of the coagulation profile of the patient. So basically, we want to give platelet, we want to give FPs or cryo. It depends on the interpretation of the result. This is very important. Cell salvage is the technique which is recommended, especially for abdominal aortic aneurysm, especially if the patient is stable and you have time. But again, you have to have arranged blood cells in the OR along with the products should be in the hand but before starting the surgery.
Sir, are there any protocols or guidelines regarding arrangement of blood according to particular surgical procedure? Any particular hospital guidelines available? Or
Basically, most of the hospitals make their own guidelines, or the universities or the societies, they make their own guidelines and implement in their region depending on which kind of patient they are dealing with and what are the population and what are they presenting with. Major, for example, specialty hospitals, they develop their own guidelines and implement them. So the key here is to have all the stakeholders and then make a committee, which is usually called blood utilization committee, in which there are stakeholders from the operating room like anesthetists, surgeons, then there's stakeholders from the blood bank, their physicians and their technicians, and they sit down and they develop a guideline for particular procedure, how much they are, what is the percentage of transfusion in a particular surgery, and depending on the type of surgery and the type of patient they are getting, they develop protocol for each and every procedure, including elective and elective surgeries.
Okay. Any question from audience, junior colleagues to the panelist? Anyone? Okay, we end our panel discussion with key points that according to the guidelines, main point is for hospitalized adult patients, red blood cell transfusion be administered using a restrictive strategy. Okay, this is the main today's key point. And if available, please use point of care testing devices for major surgeries. Okay. Now, I would like our chairpersons to please come here to give certificates to our panelists. Yeah. Okay, Dr. Akhtar Aziz Khan. Professor Nasreen Lai. Dr. Khalid Samad. Professor Mohammad Sirajuddin. Okay, I would like to call Dr. Zahid Rao to please come on the stage. Dr. Zahid Rao is here or not? To give the certificate to our chairpersons. Okay, I think Dr. Zahid is not here. Dr. Fozia, will you please come on the stage to give the certificates to our chairpersons? Okay. Professor Syed Tipu Sultan. Professor Khalid Bashir. Oh. So, certificate to myself.